The human body is a complex and wondrous living machine. Like any machine, our bodies are composed of smaller parts that work together. The various tasks that are performed each day, such as breathing, eating and digesting food, and the movement of our blood, are performed by specialized structures known as organs. Examples of organs include the lungs, stomach, heart and brain. All of these organs and other body parts like our skin and muscles are made of smaller living units called cells. Our lungs are a good example of how many cells work together to perform a specialized task. The cells in our lungs work together to allow us to take in oxygen from the air and get rid of waste products such as carbon dioxide. Our lungs are composed of many millions of cells working together to accomplish this task. Cancer is the result of a long process that begins when one of the cells in an organ or tissue becomes damaged or altered in a way that causes it to break free from the normal controls that allow our cells to work together in harmony. A group of misbehaving cells can cause the same kinds of problems in a body that a defective part would call in any other type of machine. A normal cell will divide only when it receives the chemical signal telling it to do so. These signals are interpreted. The nucleus and the cells reproduce their genetic information and divide into two identical daughter cells through a process called mitosis. Cancer cells do not obey this rule and will divide it even if they do not receive appropriate signals. In addition to the signals that normal cells with, telling them to divide, they're also told when to stop dividing. This prevents too many cells from being made. In fact, the cell division price. This is a highly ordered process. This is a critical issue in cancer because cancer cells do not obey. All require normal signals for division. This can the formation of a mass of cells that piles up and may form a tumor. Also different from normal cells. Ability of cancer cells to continue dividing indefinitely. An important point about cells is that no matter what their job is in the body, they all have the same general structure. The cells that make up our lungs, heart or brain are all similar in their overall appearance even though their jobs are quite different. Just as the organs that the form are made of smaller structures, cells themselves are composed of smaller parts that help them perform their jobs. These smaller structures are called organelles. Of particular importance in cancer is the organelle known as the nucleus. The nucleus can be thought of as the brains of a cell. It contains the information that acts as the blueprint for each and every one of us, just as a manual would contain instructions to assemble a chair. Specifically, this information is contained within the chromosomes that reside in the nucleus. Individual units of information are called genes. At a chemical level, genes are made of deoxyribonucleic acid or DNA. All of our cells contain the same set of information. It is only how the information is used that makes them different. For example, cells in the lungs use different bits of the blueprint to do their job than the cells in our stomach. And cancer changes to the DNA because some of the genes to fail to perform what to do their job in a way that causes problems with the affected individual. In short, all cancers are thought to result from changes to DNA, alter critical genes and change the behavior of the affected cells. If a change occurs to the nucleotide sequence, it is like having the letters of a word changed. An alteration in a team is called the mutation. How do all these changes occur? There are actually a number of different things that can cause mutations. Examples include chemicals that can be swallowed or inhaled, such as those found in chewing tobacco and cigarette smoke, and radiation from the sun, or artificial sources like a tanning bed. Sometimes mutations occur without any known external because they just happen. Certain genes make products that lead cells to reproduce. This would be equivalent to the gasoline system in cars. Genes that are responsible for making seltzer cider are known as proto-oncogenes. Changes in these normal genes lead to the production of oncogenes. The result may be cells that divide in the absence of proper signals. It is the equivalent of a gas pedal that is stuck in the on position, making a car go even when no foot is pushing down. Genes whose products function as the equivalent of cellular brakes also exist. As a group, these genes are known as tumor suppressors. Humans have two copies of each gene, one inherited from each parent if a single copy of a tumor suppressor is damaged. Other copy is usually able to stop the cell from behaving abnormally. This would be like losing either the front or rear brakes of a car. The car may be damned, but we still be able to stop. But if the second set of brakes is damaged as well, the car would not be able to stop. Cell will not be able to stop dividing if both copies of the tumor suppressor genes are damaged. The process by which to me is because the body to provide them with nutrients is known as angiogenesis. Like the hungry plant in the little shop of horrors, a growing tumor sends out signals that essentially say, "Feed me." The message is from the tumors because nearby blood vessels to send over new extensions that deliver food and oxygen. Importantly, the blood vessels also service the passageway for the movement of tumor cells to neighboring and distant parts of the body. Spread of tumors to distant locations is of great importance in cancer. About 90% of the deaths due to cancer involve tumors that have spread around the body. The movement of tumor cells to other parts of the body is known as metastasis. Metastasis is a complex process during which cancer cell to break off of the original or primary tumor and move to the body to form tumors at new locations. From the point of view of a cancer cell, this is a dangerous and often unsuccessful process. The trip through the body is full of hazards that cause the death of most cells that begin the journey, even tough cancer cells. To begin the process, individual cells must break away from the tumor and invade nearby vessels. The cells crawl along the surface of other cells and the fibrous stringy structures surrounding them and then force their way in. Shown here is the invasion of the blood supply. Inside a blood vessel, the cancer cells may perish from a variety of causes. Some cells to die simply because they are unable to survive floating around in the bloodstream. Others may become damaged and die when they squeeze through tight spaces or bump into the wall. All of the blood vessels. Still, other migrating cells may be recognized and destroyed by cells of the immune system. How and where the migrating cells stop is different for different cancer types. Once the tumor cells are no longer moving, they can begin the process of forming a new tumor by leaving the blood vessel and beginning to reproduce in the new location. This does not always occur, and cells that have made it this far may still die or fail to divide. If the new environment is suitable, the newly arrived cell will begin to grow, and a new tumor will develop. One way that the development of cancer is prevented is via the death of defective cells. A cell that becomes mutated or damaged will first attempt to repair the damage. If that is not possible, the cells will commit the cellular version of suicide. An orderly process called apoptosis leads to the breakdown of key cell parts and the death of the cell. Cancer cells lose this critical capability and will continue to divide. This can lead to the accumulation of cells that can become more and more abnormal. Due to the high rate at which cancer cells accumulate mutations, a tumor that originally started as a single abnormal cell is actually made up of many slightly different cells. They are all cancer cells that are similar to each other, but they may not all have the same sensitivity to any particular cancer drug or treatment. When this mixed bag of cells is exposed to a draw, most of the cells will probably die. Those cancer cells that are resistant to the treatment may reproduce to reform a new tumor. Importantly, this new tumor will be unlikely to respond to the same treatment. Their mutations make them invulnerable to that drug. If you have cancer, your doctor may recommend chemotherapy as part of your treatment. The cells in the body grow and divide as part of the normal cell cycle. The cell's nucleus controls this process. Inside each nucleus, genetic material called DNA contains the instructions for directing this process. Sometimes the cell's DNA becomes damaged. Normally the DNA responds by either repairing itself or instructing the cell to die. In cancer, however, the parts of the cell's DNA that direct cell division become damaged. When these sections are damaged, the DNA is unable to repair itself or because the cell to die. Instead, the unrepaired DNA causes the cell to grow and divide uncontrollably into more damaged cells called cancer cells. A tumor forms as the cancer cells multiply and displace the normal cells. As the tumor enlarges, it develops its own blood supply. Since cancer cells do not stick together as well as normal cells, they may break away and enter a nearby blood vessel. Cancer cells and blood vessels may travel to other areas of your body and form additional tumors. This is called metastasis. Additional tumors may form in areas such as the lungs, liver, and bones. Another way cancer may spread to other areas of your body is through your lymphatic system. Cancer cells may enter lymph vessels near the tumor, then travel to small glands called lymph nodes. If the cells passed through the nodes, they may continue to travel through your lymphatic system and form additional tumors. Chemotherapy drugs work by targeting fast-growing and reproducing cells, a characteristic common to cancer cells. The tumor shrinks as the cells stop dividing and die. Most chemotherapy drugs work systemically as they travel throughout your body and your bloodstream as they circulate. The drugs damage metastatic cancer cells and other organs. Unfortunately, chemotherapy drugs cannot tell the difference between fast-growing normal cells and cancer cells. As a result, these drugs also damage or irritate some of your fast-growing normal cells, such as those in your bone marrow, digestive system, and hair follicles. Death, irritation, or damage to these normal cells produces side effects such as a weakened immune system, nausea, and hair loss. The goal of chemotherapy is to reduce or eliminate cancer cells in the original tumor and any sites of metastasis. In addition to being a primary cancer treatment, doctors often use chemotherapy as a secondary treatment before, during, or after other primary cancer treatments such as radiation therapy or surgical excision of a tumor. Depending on the location and type of cancer, you may receive chemotherapy drugs intended to circulate throughout your body, including pills, capsules, or liquids taken orally, and intravenous or intramuscular injections. Alternatively, you may receive drugs delivered only to the area of the tumor. One local method delivers drugs to your bladder or chest through narrow tubes called catheters. Another local method injects drugs into the cerebrospinal fluid surrounding your brain and spinal cord. A third local method places slowly dissolving wafers into an area where a tumor was removed. In most cases, you will receive a number of different chemotherapy drugs to increase their effectiveness. You may receive many chemotherapy treatments spread out over a period of weeks or months. This allows your body to recover between treatments and to kill as many cancer cells as possible. Common side effects of chemotherapy include hair loss, nausea, decreased appetite, fatigue, anemia, bruising, and diarrhea. It is important to rest, eat nutritious foods, and take medications prescribed by your doctor to reduce or minimize the side effects. This is a short video on chemotherapeutic agents. We have a few for scattered pictures and diagrams here. To start, on the left we have vinca alkaloids and taxanes, which are two classes that affect microtubules. We'll talk about how those affect microtubules and the action of killing cancer. We have in the middle the two topoisomerase inhibitors, and we're gonna talk about those can lead to cell death as well as a couple examples of those. And on the right here we have a general graph that shows how when we use chemotherapy to gauge, and we want to ensure that they kill cancer cells better than they kill normal cells. So we're gonna jump right into talking about the classes of these chemical agents used in the treatment of cancer. This is chemotherapeutic agents. Where to start with alkylating agents? First, this is the first class we're going to be talking about now. Alkylating agents in general attach alkyl groups to DNA. They usually attach groups between two base pairs, allowing for cross-linking of base pairs. This of course damages the DNA, makes you unable to replicate it, and it kills the cell that way. Now the good thing about alkylating agents is that they are not specific to any part of the cell cycle, so they should be working on all cells regardless of what part of the cell cycle they're in. We have some common typical alkylating agents here. We have typical and atypical alkylating agents. When start talking about the typical ones, the two that are hard to know, or cyclophosphamide and if possible. Now there's a whole list of side effects of these, and a lot of them are the ones that you might class we think of as side effects to chemotherapy. We have myelosuppression, which means a drop in white blood cells, drop hemoglobin, and a drop in the credits. We have nausea, vomiting. That's the big one. Everybody's scared of nausea and vomiting when getting chemo. We have secondary malignancies. We have infertility and hemorrhagic cystitis, which is a problem in the kidneys. You get blood in the urine, and you have team with urination caused by the irritation the bladder from the acrolein metabolite. Now we have a typical alkylating agents as well. We're sort of talking about the platinum compounds. These work by covalently binding purine DNA bases. When talk about these first we have cisplatin, which has side effects of nephrotoxicity and nausea and vomiting. This is actually the strongest inducer of nausea and vomiting that we're talking about today. It's extremely pleasant potency, and it almost certainly causes vomiting the patient if you don't give them any medication for vomiting when you're administering cisplatin. Have carboplatin, which causes platelets problems, and we have oxalic which causes cold sensitivity. And it's worth mentioning that all of these planning compounds also cause peripheral neuropathies, or like the pins and needles tingling in your fingers and toes. Next group of atypical alkylating agents are the nitrosoureas, and these are two acronyms, BC and UCC and U. The actual names for these drugs have MOS in them, M.U. S like car musty, and it's because they are related to mustard gas that was used during one of the world wars, so it's easy to remember that these which are related to mustard gas, if you look at the full names of them, cause pulmonary toxicity. And it's also worth mentioning that they also because phlebitis and central nervous system problems to deserve that alkylating agents. Next one to talk about antimetabolites as of three categories of these, but first into metabolize inhibit DNA replication by mimicking a normal cell compounds, and because these are inhibiting DNA replication they're specific to cells that are in the S phase, because you undergo de novo replication and the state is. First we're gonna talk about is folate inhibitors, and the big one here is methotrexate. Very commonly used drug inhibits dihydrofolate reductase, which is an enzyme that prevents the regeneration of a hydrophilic and inhibits the conversion of folase, which is a dietary supplement, something that we get from our food, into such a hurtfolate. When we administer methotrexate we always want to do it with looking for and look of orange is an adjuvant that protects the healthy cells. It actually gives the healthy cells another method of getting folate, another method of using folate, and up methotrexate a look of horror and go together for that reason. Side effect of methotrexate is mucositis and myelosuppression. Mother's person's gonna come up quite a bit. Mixed group of antimetabolites are the perimeter and the editors. Big one here is 5-FU-5-fluorouracil, which inhibits the enzyme Simon delayed synthetase. When you administer 5-FU as a bolus it's gonna cause myelosuppression. If you administered in a continual dose can cause GI problems like diarrhea, mucositis, so the side effects of a 5-FU depend on how you administer it. You also wanna use look of armed with 5FU for a different reason this time looking for and helps the mechanism of action of 5FU when you use methotrexate, and look of orange looking for and protects the healthy cells when used by the FU, and look of foreign tensites the mechanism of action of 5FU. It's worth noting the difference of look of horror in between its use and methotrexate and 5-fluorouracil. Capecitabine is essentially an oral prodrug for 5-FU. Now 5-FU would normally is not administered orally. Capecitabine a prodrug, which means that it must be further processed in the body before it becomes active. That's cited in one of the side effects of keeps happening this hand-foot syndrome. Your palms and your feet become red, they can start blistering. In the last of the permitting and editor's side terribly, in which is a ravenous C, it's a DNA chain terminator. So the fact here is conjunctivitis and cerebral neural defects. So RC or so terribly and causes conjunctivitis and cerebral defects. So RC concerned about us cerebroneural defects. It's also worth mentioning that so terribly and is the 7 and 7 plus chemotherapy given her, that it's like a 10-day regimen of chemotherapy. That's very common. For the first 7 days are gonna be administering side terribly in. For 3 days of answer cyclins, we'll talk about after cyclones and second. And there's one other class of antimetabolites called the purine analog, and the one that is important now is 6-mercaptopurine. Is remember that as a parent along 6-mercaptopurine. So we have 3 classes of antimetabolites, which is a larger class of chemotherapy drugs now fully interpreters, permitted innovators, and sharing that logs. Now another class, microtubule targeting agents. These drugs inhibit mitosis of course. During the end phase they are specifically targets the microtubule activity during mitosis. Rants about how they do that. Think alkaloids firstly destroy microtubules is remember vinca alkaloids destroyed microtubules, and that obviously prevents their function. 3 think alkaloids are listed here, BLAS is underlined. You'll see why in a second. Side effects of the alkaloids are peripheral neuropathy and the suppression. BLAST is the strongest of those 3 in suppressing the immune system. So BLA-vinc, then blasting is the strongest. Less suppressive a therapeutic drug has the strongest side effects. One important thing to remember about think alkaloids that you cannot inject them directly into the spine. They're fatal if given intrathecal. Next group of microtubule targeting engines are the taxanes. These stabilize microtubules, which prevent them from doing what they actually need to do, which prevent the microtubules from actually touching the chromosomes and pulling apart. During that it is so think outwards destroy them. Texans stabilize them, both render them useless. 2 texans are paclitaxel and docetaxel. Side effects of these are mother suppression orders, and that a lot in peripheral neuropathies. It also hypersensitivity associated with these, and it's important now that hypersensitivity doesn't come from the drugs, doesn't come from paclitaxel and docetaxel directly, but rather it comes from the diluent that the drugs are dissolved in. These billions crumb cream before and tween 80 both cause hypersensitivity. The one from paclitaxel cream before is a little more potent. We don't want to deal with this hypersensitivity. We could also administer Abraxane, which is a different formulation of paclitaxel. It's protein-bound paclitaxel, and it helps us avoid hypersensitivity that's involved with the cream. For Doug Williams and paclitaxel, one of the trade-offs of using Abraxane versus paclitaxel is that you have more in Iraq with you, so you have less hypersensitivity, but more men are up at the X-class Tomboy Summers innovators. There's TOPA Summers 1, TOPA Summers 2. The ones that inhibit TOPA 1 prevent the relaxation of supercoiled DNA. To these remember to put UCAN and IRAN-IRENO TKO and IREDA ticket has a fun mnemonic to help you remember what it does. We'll get in that second is whether these caused by the suppression, like almost everything else to talk about. I read that you can cause diarrhea is remember because I read that you can't sounds like you ran to the can, you run to the can when you have diarrhea caused by renotikin. Tokyo 2 inhibitors prevent recoiling of DNA after transcription. Couple this remember are tocoside and 10 at the side both, and again assigned top or summaries to inhibitors. Both have side effects of myelosuppression and secondary malignancies such as housing AML, acute myeloblastic leukemia. These are the 3-4Ns that are associated with top of 2 inhibitors such as the topicide and turned up the side. Next class so we want to talk about are the anthracyclines, and recycling can have an ambiguous mechanism of action. They do a bunch of stuff. They could do more than one of these, they could just do a few of these. Some of them are listed here. They can intercalated now, which means that they insert themselves between the actual to actual strands of DNA, preventing their replication and preventing synthesis of RNA from the DNA, so they intercalating, and I am just hit with the use of that. They can also inhibit topoisomerase to one of them ducts ribbons, and in particular inhibits topoisomerase 2. They can generate reactive oxygen species that cause oxidative damage to the DNA, and they also might cause alkylation, which, like we saw with alkylating agents, can cause cross-linking between DNA base pairs and socially render the DNA useless, kinda like intercalation of DNA. After seconds, or as remember, because they all end in Rufus, and these are the ribbons and Stocks ribbons, and Donna revision and read the rest there. I'd Robinson and after Robinson. Side effects of these are pretty common to all of them: biventricular heart failure, and this is based on the dose, that cumulative dose of the ribbons and administered, so there's like a limits for each of these rivers, and so Dr. Mrs. Limit might be some number, can only give a person so much doxorubicin before they hit that number and be at a statistically significant increased risk for biventricular heart failure. Another side effect for the anthracyclines is that they are necrotic with extravasation. This means that if you, when you're normally injecting these into the veins, if you miss the veins and accidentally get somebody's anthracycline into the surrounding tissue, can cause necrosis of that tissue, leave very nasty looking, will stick it, tear up somebody's whole arms, hurt somebody's wrist if you miss when inserting a vein. So nurses are trained really well to be very careful about administering anthracyclines. You want to look at some pictures of this. Looks pretty nasty. It's kind of fun to look at. You can look up and recycling extraversion, and it should be pretty easy to find. It's also worth noting the anthracyclines are the 3 and the aforementioned 7+3 chemotherapy, so you have 7 days of side terror being followed by 3 days of one of the other cycling sisters, doxorubicin. Next class, or the monoclonal antibodies. These are antibodies are synthesized to a specific targets that has been known to inhabit cancer. We'll give you a bit more detail here. The origin of the monoclonal antibodies can be determined from the suffixes, so monoclonal antibodies, and you can come from mice. Mouse is easier to remember from a map from else. The X, I, M, A, B ending or IMA. From the time Merrick and about his, these kind Merrick antibodies are cross between human and mouse, so they have some human in them. This list, by the way, it is in decreasing order of how much mice is involved in these antibodies. So this new map, this next one is humanize, which means it's about 10% mouse, 90% human, is remember, because map is a unit just like human. Then finally the fully human antibodies are called mu-map. That these new maps are 100% human, so I believe that the chimeric antibodies are about 33% human. Does anybody there about 10% human, and the fully human and about is using the new map antibodies are about 10% mouse, and the fully human antibodies are about 0% mouse. We have a list of 4 important monoclonal antibodies that are probably worth knowing. Start with where talks about a very timely used to target CD20, which is a receptor very common to B cells. It's used to treat lymphomas or the abnormal proliferation of B cells that you often see in lymphomas, and we're not gonna when I have it's causing the toxicity for the first 2, but target CD20 used for them from us. There's another one used for breast cancer, targets HER2, also not a significant, so Toxamat targets the AGFR receptor and failure growth factor receptor. This is used to treat solid tumors, and it was initially developed to treat colorectal cancer. One of the side effects of the Toxamat is that you can hypersensitivity in the form of an active form rash, so looks like you have dots all over your skin, you get a rash. She used to talk about. Another one that's worth knowing is dazobevacizumab, which targets about GEF, which is a vascular endothelial growth factor, also used for solid tumors, initially developed for colorectal and lung cancers. This problem because it can cause GI perforation, but GEF is a factor that promotes angiogenesis, promotes the growth of blood vessels into new parts of the body or into tumors. If you inhibit those, you can weaken the GI tract because perforation of the GI tract. And finally we're gonna have a short list of other chemotherapeutic agents. My son is worth noting because it causes long toxicity just like the ones related to mustard gas that we talked about earlier. The nitrosoureas leomycin also causes long toxicity. So the facts of this long toxicity include how many fibrosis, interstitial pneumonitis and hypersensitivity pneumonitis, which includes cough or having infiltrates in the lungs. And there are a couple other hormonal therapies that are worth knowing. Some of these are for breast cancer, specifically the anti-estrogens such as tamoxifen and the aromatase inhibitors. Rheumatism, I think I've been examples here, but they block the synthesis of estrogen. Actually are a couple examples ending in nozzle, so the one that's important to know is the anti-estrogen tamoxifen. Are also some hormonal therapies for prostate cancer such as the anti-androgens, and there should be a small list of the like the H.R. agents agonists, Serge has Royal HRH agonists, the G and RH antagonists, and CYP17. And if you look up the production of testosterone, you can kind of see how these three subclasses of anti-androgens all kind of inhibits testosterone production in a different way, all with the eventual goal of preventing androgen stimulation of prostate cancer. So these are other Cuba therapeutic agents that didn't really fit into the other categories. This has been a brief review of chemotherapy agents. I hope it was helpful, and I hope it was a good introduction to commonly used drugs and their mechanisms of actions and side effects. Thanks for listening. Chemotherapy. Chemotherapy is one of the modalities used in the treatment of cancer patients, often in conjunction with surgery and radiation therapy. Cells in the body grow and divide according to the normal cell cycle, which is controlled by the nucleus. The genetic material or DNA inside the nucleus contains the information necessary to execute this process. If the DNA in the nucleus gets damaged, it either repairs itself, sends instruction to the cell to die. In the case of cancer, the portion of the DNA that controls cell division is altered, resulting in the DNA unable to repair itself and instruct the cell to die. This causes the cell to grow and divide uncontrollably, creating multiple copies of itself called cancer cells, which displays normal cells to form a tumor. As the tumor increases in size, it also begins to develop its own blood supply. As cancer cells do not adhere to each other rather compared to normal cells, they tend to break away and enter the nearest blood vessels, and thereby spreading to other parts of the body in a process known as metastasis. Other common metastatic sites include the lungs, liver, bone, and brain. Metastases may also occur through the lymphatic system, with the cancer cells entering the nearest lymph vessels, from which they migrate to the lymph nodes and the rest of the lymphatic system, spreading the cancer to the other parts of the body. Gamma therapy works by selectively targeting fast-growing cells, which is typical of most cancer cells, causing the tumor to shrink because of the degree cell division and death of the cancer cells. Most chemotherapy drugs act systemically by entering the bloodstream to reach the metastatic cancer cells and various organ sites. However, as they are unable to tell the difference between a cancer cell and a fast-growing normal cell, they often end up attacking normal cells such as those of the bone marrow, digestive system, and hair follicles. Common side effects of chemotherapy include 1. Frequent infections because of a weakened immune system. 2. The idea. 3. Nausea and loss of appetite. 4. Hair loss. 5. Bruising and anemia. The objective of chemotherapy is to reduce or eliminate cancer cells in the original tumor site as well as in the other sites of metastasis. Chemotherapy may be either a primary or secondary means of cancer treatment, along with surgical excision and radiation therapy. Chemotherapy drugs may either be given systemically through pills, capsules, or liquids administered orally, intravenously, intramuscularly, or locally such as through catheters. For tumors in the chest of bladder, Injections into the CSF. Asked slowly dissolving V first. After the DUMA has been removed. Can without a bead. Drugs are often used in combination in order to increase their effectiveness and are generally spread out over a period of weeks or months to enable the body to recover between treatment cycles, as well as to kill as many cancer cells as possible. Given that AD patients are often advised the following: 1. Adequate rest. 2. Nutritious diet. 3. Medication to minimize the side effects. Welcome back. We're now going to talk about the different types of treatment for individual cancers. As we have learned throughout this course, lung cancer is the most common cancer in men and women. Actually 220,000 people are diagnosed per year in the United States and 1.5 million people are diagnosed worldwide. This is the leading cause of cancer death around the world. Notice there's 160,000 deaths for 220,000 diagnoses in the US and 1.3 million worldwide, when only 200,000 more people are diagnosed every year. This is because most people present with metastatic disease that is not amenable to surgery or radiation for sure, because the disease is metastatic at diagnosis. Survival is generally measured in months to a few years for lung cancer at the time of diagnosis. Let's look at the potential treatments for lung cancer if it's localized. The whole idea again is to get that cancer out or to treat it with radiation, and surgery is used to remove the cancer, and that means also removing part of the lung. So a new man next to me is the removal of an entire lobe of the lung on the left to the right side. A lobectomy is to just remove a section of the line, like one half of one side, and a wedge resection is for a very small cancers where you just remove the cancer and part of a lot of where the cancer is sitting. Radiation is used when surgery is not possible or if some cancer is left behind after surgery. The treatment of metastatic disease and lung cancer is usually a combination of chemotherapy and targeted therapy. There are many drugs with activity usually given in a doublet combination, so you'll see says platinum plus Taxol or carboplatin plus Taxotere. Many regimens have been shown to have activity. In addition, you'll see patients treated with a doublet plus of accident or a doublet plus Tarsuva if the cancer is noted to be overexpressing EGFR. There are a small percentage of non-small cell lung cancers, about 5% of them, which overexpress the gene. Now if that is the case, the doublet is also used with Excelcori, which is the medicine that targets the ALT mutation. In 2015, checkpoint inhibitor blockade was approved for the treatment of metastatic lung cancer, and now immunotherapy is another way to treat metastatic lung cancer. Moving on to breast cancer. In previous lectures we've learned that breast cancer is the most common cancer in women in the United States. Approximately 230,000 cases are diagnosed per year. It's the second leading cause of cancer death in U.S. women. Approximately 40,000 deaths per year. Notice here the discrepancy between the number of women diagnosed with breast cancer, 230,000 compared to 40,000 deaths. That's because the majority of women diagnosed with breast cancer in this country have a localized disease that is sure to buy surgery or radiation with or without some of that adjuvant therapy we talked about. Survival for breast cancer then is generally measured in years, even for metastatic disease, because the treatments we have are much more effective than for lung cancer. If a woman has potentially localized disease, the primary treatment is surgery with mastectomy, meaning removing the breast, or lumpectomy plus radiation, where the surgeon removes their breast cancer lump and then radiation is given to the rest of the breast to sterilize any microscopic disease. These are considered equally curative for localized breast cancer for women at higher risk of recurrence after surgery or radiation. A combination of drugs are used in the adjuvant chemotherapy setting, including atormycin and the tax savings 5 if you say tax and a cargoplane. In addition, if the breast tumor is found to overexpress HER2, Herceptin is added in the adjuvant setting. If a woman is diagnosed with metastatic breast cancer, many chemotherapy drugs are given in different combinations, including the tax savings and the platinum agents. But women with metastatic breast cancer also benefit from hormonal therapy because the breast cancers express estrogen receptor and are known as ER-positive and/or the progesterone receptor and are known as PR-positive. Hormone therapy to target the estrogen receptor is used in the adjuvant or metastatic settings to treat breast cancer alone or in combination with chemotherapy. The most famous drug that blocks estrogen binding is a drug called tamoxifen, and other newer agents include the aromatase inhibitors that block estrogen production, including Femara and Arimidex. In addition to chemotherapy and hormone therapy, targeted therapy for breast cancer includes drugs that block HER2 like Herceptin and drugs that block mTOR as well as the cyclin kinases. Moving now to prostate cancer, the most common cancer in men. We know that very similar to breast cancer, approximately 220,000 men will be diagnosed with prostate cancer every year in the United States. It is the second leading cause of cancer death in men after lung cancer, and approximately 27,000 men die in the U.S. yearly. Again, just like we saw in breast cancer, the majority of men diagnosed with prostate cancer have localized disease and are cured with surgery or radiation. The men who have metastatic disease are treated effectively with hormone therapy and chemotherapy and have a survival measured in years. So looking closer at treatment for potentially localized disease, radical prostatectomy, where the prostate is removed by the surgeon, and external beam radiation therapy are considered to be equally curative for localized disease. If a man is believed to have locally advanced prostate cancer where the disease may have spread just outside of the prostate, external beam radiation plus 2 to 3 years of hormonal therapy in the form of medical castration is the therapy of choice for locally advanced disease. Active surveillance, where a physician actively follows a patient without surgery or radiation, can be utilized for low-grade cancers. If prostate cancer has metastasized, hormonal therapy is the first-line treatment for prostate cancer. Hormonal therapy is designed to decrease circulating testosterone. The most common hormonal therapies are those drugs that tell the brain to not stimulate testosterone production. Other drugs can be used in combination with these agents that block testosterone binding to the androgen receptor in the cancer cell. Once these drugs are no longer effective, second-line treatment includes hormonal agents that induce supercastration, meaning lowering the testosterone even lower. If those drugs are not effective, the chemotherapy agents Taxotere and Geftana and Nobanprone are used to help people live longer. The bone-targeting radionuclide ex vivo is also used, as well as the cancer vaccine prevents. For those of you who are interested in learning about prostate cancer in more detail, we have a separate module that you can take. Moving on to calling him sir. This is the third most common cancer in men and women, with approximately 93,000 people diagnosed per year. It's the third leading cause of cancer death, with approximately 50,000 people dying per year in the U.S. As what we've seen, most primary colon cancers are adenocarcinomas. Again, the main treatment for colon cancer is surgery. It allows correct staging, it prevents future blockage of the colon and prevents bleeding from the cancer. Radiation is rarely used to treat primary colon cancer. If the colon cancer has invaded or spread at the time of surgery, chemotherapy is used in the adjuvant setting. The most common regimens are FOLFOX and kickbox, which use the drugs shown to really target dividing cancer cells after surgery. If the colon cancer has already metastasized, common chemotherapy regimens are often built to 5-fluorouracil. In addition to chemotherapy, many patients are treated with the targeting agents, either Avastin to target VEGF or Erbintox to target the GFR. Liver cancer is one of the most common cancers worldwide, especially in sub-Saharan Africa and Southeast Asia. So almost while it is uncommon in the US with only 36,000 new cases diagnosed, there are almost 700,000 cases diagnosed around the world, and this is a very lethal disease because it is not amenable to therapy with surgery for cure. This results in approximately 600,000 deaths worldwide yearly and approximately 24,000 deaths in the US. Again, survival here is measured in months for metastatic disease. If patients do have potentially localized disease, it turns out that liver transplant is the best option if possible. This is done for small tumors, meaning one tumor smaller than 5 cm across or 2 to 3 tumors that are no larger than 3 cm. If a liver transplant is not available or not possible, surgery is still attempted. Or in small tumors, tumor ablation with radiofrequency ethanol or chemotherapy through the artery feeding the tumor can be used to try and treat the cancer. If the liver cancer is diagnosed in the advanced or metastatic disease state, there is no systemic chemotherapy that has been demonstrated to be effective, and the one therapy that does add months to life is a targeted therapy with a drug called srafenib, which inhibits both the VEGF receptor and the platelet-derived growth factor receptor in liver cancer cells. Sometimes in a Pale-this setting, intrahepatic arterial therapy is used with the regimen F.U. doctor to try and shrink the liver cancer. For those of you who are interested in learning more about liver cancer and liver cancer treatment, there is a subsequent module that you can take. Another common cancer worldwide that is very lethal is stomach cancer. Approximately 1 million new cases are diagnosed every year, mainly in Southeast Asia and South and Central America. Of these million cases, about 700,000 men and women die worldwide yearly. You can see that in the US the number of new diagnoses is 25,000 with 11,000 deaths. Again, stomach cancer is rarely diagnosed when it is localized and amenable to surgery, resulting in metastatic disease that is very hard to treat, and survival is measured in months. Surgery is the mainstay treatment. It's often used in conjunction with chemotherapy and/or chemotherapy plus radiation therapy in the neoadjuvant setting, trying to shrink the cancer so that it can be treated with surgery. If the cancer has already metastasized, chemotherapy with the ECF regimen is the most commonly used regimen, and more recently targeted therapies are being added that target either VEGF or, in approximately 20% of stomach cancers, HER2 through the use of Herceptin. This ends our section on the treatment of common cancers. We reviewed the treatments for lung cancer, colon cancer, breast cancer, prostate cancer, liver cancer, and stomach cancer. Radiotherapy is just one treatment option your doctor may recommend on its own or as part of a combination to treat your cancer. The treatment area. A number of treatments depends on your specific type of cancer or any other treatment you have had. So we're going to have radiotherapy. Treatment is painless, and she takes between 10 and 20 minutes each day. It is similar to having an extra taken. It uses ionizing radiation or high-energy X-rays, which work to destroy the cancer cells in the trade area. Precision planning aims to give the highest chance of caring for shrinking the cancer, analyzing the treatment of healthy cells, under chasing the risk of side effects. The process does not make you radioactive. I did just see it for you to be around others, including children. Depending on your individual treatment plan, your doctor may recommend that radiotherapy treatment is to be given inside or outside of the body. External radiotherapy uses a machine, a linear accelerator, not, and is the most common type of radiotherapy. It delivers targeted and precise extra beams. The targeted radiation delivered from the neck cannot be seen or felt and is similar to that used when taking an extra for broken. A team of clinical research radiographers are employed by the Northern Ireland Cancer Trial Centre. The Cancer Centre clinical trials help to improve knowledge about cancer, develop new and hopefully better ways of looking after I'm treating patients. Your doctor will discuss your treatment options and any clinical trial that may be suitable for you. Before you begin treatment, you will attend specialist radiotherapy planning appointments and the radiotherapy department assessments. Wait at the Cancer Centre, Belfast City Hospital. Here you will be given specific information about your radiotherapy treatments and the doctor will ask you to complete consent form. The doctor will discuss your radiotherapy treatment and any side effects, both short-term and long-term. This information is very important so that you can give your informed consent to the radiotherapy treatments. The radiotherapy planning appointments may take up to 2 hours. We have a city simulator specifically designed for planning radiotherapy treatments. You may have to lie in a special board so that you're in the same position each day for radiotherapy treatments. We may need to give you an oral or injected contrast dye. This will help us to see the area we want to treat more clearly. We will let you know if we need to do this. The radio go first. We'll need to place some markers on your skin which show up on this guy. Once the radiographer's hobby in position and you are as comfortable as possible, the cuts will be made through the scanner. Discounts should only take a few minutes during this guide. Radiographers will watch you from the control area. After the scan, radiographers will make permanent ink marks on your skin. Physical touch taste and will be about the size of a pinpoint. They're an essential guide to your treatment and assure you lie in the exact position for all future treatment appointments. Advice will be given a planning as regards looking after them. We have a large action machine called a simulator. This is similar to the treatment machines. You will lie in the position we need you to be in for treatment. With the treatment exposed, the radiographers will take some X-rays to check that your treatment position is exactly as your doctor has planned. Some people will only office at one of these machines. Others may come back to this machine during treatment. This will depend on the treatment you're having. Your doctor will discuss this in more detail with you. There will be no results from any of the scan, as they are only used to plan your radiotherapy treatment. Sometimes it may be necessary to have some personalized equipment, such as a mask. These are usually designed and fitted to Jerry ointments. Normal during daylight, the radiographers to accurately positioned. Once your radiotherapy planning appointment is finished, you will be able to go home. In most cases, you will be contacted at a later date by telephone or letter with details of your first radiotherapy treatment appointments. Following your radiotherapy planning appointments, your doctor, with the help of the radiographers and physics team, may spend a number of weeks designing your radiotherapy treatment. This is a highly skilled process and there is a lot of work behind the scenes to produce a tailored individual treatment plan for each patient. Careful planning of your individual radiotherapy treatment, which uses a dose received by the surrounding healthy tissue, other nearby organs, and the risk of possible side effects from the treatment, It can take between 2 and 8 weeks from your radiotherapy planning appointments. Your treatment plan to be ready. Before your first treatment, your radiographers will explain what you will see and hear, and they will go over the side effects you may develop. The treatment machine may be fixed in one position or rotate around your body to give the treatment from different directions. The process will be the same as your radiotherapy planning appointment. You will need to lie on the couch with all the equipment you had for your scan and expose the treatment area. The radiographers will then use the permanent marks you had made at your planning appointment to make it into the correct position. This can mean a little shuffling and moving of your body on the couch. Your position is important, so please lie the radiographers to Navy. Once you're in the correct position, the radiographers believe. The radio consumers will watch you constantly on the CCTV. From the control area right side the room. During treatment you will be alone in the room for a short time. But the radiographers will be watching and listening to you all the time. It is important to keep still until the radiographers tell you that the treatment is finished. This process will be repeated. AIDS treatment. Occasionally it will take a little longer, as the radio first carry a routine checks on specific treatment days to make sure you're always in the exact treatment position. One is different, and radiotherapy can affect people in different ways, depending on the dose you're given and what area of your body is being treated. Most side effects from radiotherapy are minds. I'm feeling very ill. This rumor. Some side effects: tiredness, nausea, loss of appetite, sore or itchy skin for some in the treated area. Most side effects can be managed. Under radiographers will monitor you every day during your radiotherapy treatment. You will be seen and on treatment review clinic by a doctor from your team, are specially trained to review radiographer. You may also radiotherapy nursing department as part of your skin care during treatment. In addition, you may also be seen by other allied health professionals. Before multidisciplinary team, overall radiotherapy is quick, non-invasive, with most treatments given as a night patient. Both treatment is tailored to your individual needs, and as a treatment is targeted to the treatment area only, it limits the potential for side effects. The following some additional information which may be helpful for you. Before work, during and after radiotherapy treatment at the Council Belfast City Hospital, there is a children's waiting area where you can stay with your children, and a small courtyard garden located off the assessment suite waiting room. We use a buzzer system to call you for your radiotherapy treatment appointments. You will be given a buzzer each time you check in for treatment, and this will work anywhere on the ground floor of the cancer center, including the garden. If you're attending as an ART patient for radiotherapy and travel by car, you are entitled to free on-site car parking. You will be issued with a single ticket when you attend for your radiotherapy planning appointments, and awake a ticket thereafter for the duration of your radiotherapy treatment. Please remember to ask for your free car parking tickets. External radiotherapy machines are very big, may make you feel nervous when you say them for the first time. You may find it helpful to attend one of our monthly radiotherapy patient information evenings. These are usually held on the third Tuesday of each month at 7 p.m. There is a reason. Therapy, information and support service provided by the Information and Support Radiographer for patients, relatives and carriers. The Macmillan Supports and Information Center. Faster service. Provides additional support for people affected by cancer. It offers general support, a listening ear, and can help with specific things such as emotional support, relationship issues, benefits and welfare advice. Complementary therapy services also in place, kindly supported by Friends of the Cancer Center of the City Hospital.